So first I'll start the cardiac assessment with a patient in a supine 30-degree position. First I'll start by measuring jugular venous pressure, or JVP. First I'll look at both sides neck and ask him to turn his head to the left. First I'll locate the highest point of impulse or of oscillation. And I'll measure that at the sternal angle. And he is at about 2 centimeters, which is normal. Next, I will assess the carotid arteries, first by auscultation with the bell of my stethoscope. In this, I'll be listening for any bruits, and I'll have him hold his breath while doing so. And next, I'll palpate one side at a time. Next, I'll identify the landmarks that I will be referring to in the rest of the video. So first, on the right sternal border at the second intercostal space is the aortic region. The left sternal border at the second intercostal space is the pulmonic region. The left sternal border at the fourth and fifth intercostal space is the tricuspid region. And then the left midclavicular line at the fifth intercostal space is the mitral region, also referred to as the apex. So first I will assess these areas through palpation with my fingertips, assessing for heaves and lifts, and then with the ball of my hand for thrills. Okay, none were noted. So while I'm palpating, I'll also feel for the point of maximal impulse, which is best felt with the patient in the left lateral decubitus position. And the amplitude should feel like a gentle tapping. And then I will also measure the point of maximal impulse, which should be about 2 centimeters, which is also normal. Next, I will auscultate these areas using both the bell and the diaphragm of my stethoscope. For the bell, I'll be listening for any abnormal heart sounds or murmurs, and with the diaphragm, I'll be listening for normal heart sounds. While I'm auscultating, I'll also listen at the apex for the point of maximal impulse. This also could be listening for any murmurs, such as potential mitral stenosis. Okay. No murmur heard, and it's about the length of half of systole. Typically, this is also done in the left lateral decubitus position. Also, I will listen at the right sternal border just for any abnormal heart sounds as well, with both the bell and the diaphragm. And lastly, I'll have the patient sit up. In this, I will be assessing for potential aortic regurgitation. I'll have the patient take a deep breath, and on his exhale, I'll have him hold his breath, and I'll listen at the apex with the bell of my stethoscope. All right, deep breath, and hold your exhale. Okay, no abnormal heart sounds noted.